The weakness started in his feet. Not a sharp pain, not a sudden collapse, just a quiet, spreading numbness, as if the signals his brain was sending were being intercepted somewhere along the way. Within days, what began below his ankles had climbed past his knees. His own immune system, the system built to protect him, had turned its attention to the wrong target. To understand what happened, it helps to know something about the man before the illness. He was physically active, someone who used his body as a matter of routine. In the weeks before the weakness began, he had moved through an ordinary stretch of life, and then somewhere in those 3 to 6 weeks, a common infection had passed through him. A respiratory illness perhaps, or a bout of gastrointestinal distress. It resolved, as most infections do. He likely thought little of it afterward. What he could not have known was that his immune system had not fully stood down. The antibodies it had generated to fight the infection were still circulating, and they had found a new target. The peripheral nervous system, meaning the vast network of nerves that runs outside the brain and spinal cord, connecting the body to everything it needs to feel and move, was now under attack. The first sign was sensation, rather than weakness. Tingling, pins and needles in the feet, then pain in the back. These symptoms are easy to dismiss, easy to attribute to a strained muscle or a night of poor sleep. But they did not resolve. They shifted and deepened, and within days, the legs began to weaken. The weakness was symmetrical, meaning it affected both sides equally, which is one of the condition's characteristic features. It rose steadily, following the body's geography upward. The clinical term for this pattern is ascending paralysis, and in Guillain-Barré syndrome, the autoimmune condition at the center of this case, that ascent can move with alarming speed. In some patients, maximum weakness is reached within half a day. In others, it develops over 2 weeks or more. In approximately 1 in 5 patients, the weakening continues for up to 4 weeks before it plateaus. By the time a physician examined him, the tendon reflexes, those automatic responses a doctor tests by tapping below the knee, were diminished or absent. In medical language, this is called areflexia, meaning the reflex arc that normally causes an involuntary kick was no longer completing its circuit. That finding, combined with the ascending weakness and the recent infection, pointed urgently toward Guillain-Barré syndrome. But a clinical suspicion is not a diagnosis. The physicians needed to rule out other causes of rapidly progressing weakness: spinal cord compression, certain metabolic disorders, other inflammatory nerve conditions. 2 investigations were central to narrowing the field. The first was a nerve conduction study, a test in which small electrical impulses are applied to the skin over a nerve, and the speed and strength of the resulting signal are recorded downstream. In Guillain-Barré syndrome, the myelin sheath, the insulating layer that wraps around nerve fibers, the way plastic coating wraps a wire, is damaged by the immune attack. Damaged myelin slows or disrupts the signal. The nerve conduction study in this case showed the characteristic slowing consistent with that damage. The second investigation was a lumbar puncture, in which a needle is inserted into the lower spine to collect a small sample of cerebrospinal fluid, the clear liquid that surrounds the brain and spinal cord. In Guillain-Barré syndrome, this fluid typically shows elevated protein with a normal or near-normal white cell count. The elevated protein reflects the inflammation and nerve damage occurring nearby. The absence of high white cell counts helps distinguish this condition from infections of the nervous system. The results aligned. The underlying mechanism, as best as medicine currently understands it, is a process called molecular mimicry. The immune system generates antibodies tailored to recognize specific molecular patterns on an invading pathogen. In some individuals, those patterns closely resemble structures on the surface of peripheral nerve cells. The antibodies, unable to distinguish between the pathogen and the nerve tissue, attack both. The myelin insulation is degraded. The nerve's ability to carry signals, instructions to muscles, sensations back to the brain, begins to fail. This is why the weakness follows a nerve geography logic rather than a vascular or skeletal one. The longest nerves in the body, which run to the feet and hands, are typically affected first. As the immune assault continues, shorter and shorter nerve pathways are drawn in. That is the biological reason paralysis in Guillain-Barré rises from the feet upward. The most dangerous phase of the syndrome is when that ascent reaches the respiratory muscles. Approximately 15% of patients develop weakness severe enough in the chest and diaphragm that they can no longer breathe independently and require mechanical ventilation, a machine to move air in and out of the lungs. The autonomic nervous system, which controls involuntary functions like heart rate and blood pressure, can also be affected, creating further instability that requires close monitoring in an intensive care setting. Treatment was initiated promptly. Two options are supported by clinical evidence: intravenous immunoglobulin, a preparation of pooled antibodies from healthy donors that essentially dilutes and disrupts the aberrant immune response, or plasmapheresis, a procedure that filters the blood plasma to remove the damaging antibodies directly. In this case, as in the majority of severe presentations, one of these interventions was used alongside careful, supportive care. The plateau phase, the period when weakness stops progressing and holds at its worst level before recovery begins, can last anywhere from 2 days to 6 months. The most common duration is roughly a week. What followed was a slow, non-linear return of function, measured in small gains, the ability to feel pressure, then to resist gravity, then to bear weight. Recovery in Guillain-Barré syndrome is real, but it is not guaranteed to be complete. About a third of patients retain some permanent weakness. Globally, the condition is fatal in approximately 7.5% of cases, often due to complications during the acute phase. The illness affects roughly 1 to 2 people per 100,000 per year, which makes it rare enough that many clinicians see only a handful of cases in a career, but common enough that its pattern is well documented. What this case illustrates is not a failure of medicine, but a demonstration of the immune system's extraordinary and sometimes catastrophic precision. The antibodies that began as a defense did exactly what antibodies do. They recognized a molecular shape and attacked it. The tragedy is that the shape they recognized existed in 2 places at once: in the pathogen that had already been cleared and in the patient's own nerve tissue. That mistaken identity cost months of function and required the body's own recovery machinery to slowly rebuild what the immune system had unmade. The central question this case poses: why do some people develop this autoimmune response after a common infection while the vast majority do not, remains genuinely open. Researchers have identified certain pathogens, particularly a bacterium called Campylobacter jejuni, associated with gastrointestinal illness, as more commonly linked to the syndrome. But the precise combination of genetic susceptibility, immune timing, and molecular similarity that tips a normal immune response into an attack on the self is not yet fully understood. What can be said with confidence is this: early recognition matters. The difference between a patient who recovers with residual weakness and one who requires prolonged ventilation often comes down to how quickly the ascending pattern is recognized for what it is and how quickly treatment is initiated. The tingling in the feet is where the story begins. It is not where physicians can afford to let it end. Back at the beginning, the quiet spreading numbness, the signals intercepted somewhere between the brain and the feet. What seemed like a minor after-effect of an ordinary illness was actually the opening movement of an immune system rewriting its own instructions. The nerves went silent, not because they were broken, but because they had been mistaken for an enemy. And slowly, with time and treatment, the body found its way back to distinguishing the two. This video is based on a publicly documented medical case and is intended for education and storytelling only. It is not medical advice. If you are experiencing concerning symptoms, consult a licensed medical professional. Medical mysteries. Every symptom has a story. Every patient deserves to be heard. Medical disclaimer. This video is based on real, publicly documented medical case reports and is intended for educational and storytelling purposes only. It is not medical advice. If you or someone you know is experiencing similar symptoms, please consult a licensed physician immediately.